So this is one question which has recently come in the NEET PG 2023 exam. A similar question came. So the question is, a patient presented with anxiety, restlessness, tremors and fevers. His BP is 180 by 110 and on an ECG atrial fibrillation is detected. He also has a history of asthma. So what drug should be given next is the question. So how do we approach this? First of all, what is our diagnosis? Our diagnosis is, it is thyroid storm. Okay, so this is a case presentation of thyroid storm. So what is the overall drug of choice in the case of thyroid storm? It is propyl thiouracil. But as the patient is having atrial fibrillation on ECG, the life-saving drug in this case should be a non-selective beta blocker like propranolol. So it is very easy for us to get foxed by this and go for the answer as propranolol. But what is the catch in this question? The catch in this question is that the patient is having an history of asthma. And if the patient is having an history of asthma, as we all know, non-selective beta blockers are contraindicated in the case of asthma. So we have to control the atrial fibrillation, and as we know, for controlling atrial fibrillation or for controlling any supraventricular tachycardia, there are 4 drugs that we have in our armory. They can be remembered by the mnemonic A, B, C, D. A for adenosine, B for beta blockers, C for calcium channel blockers, and D for digoxin. So these are the 4 drugs which can be used as AV blocking drugs, that is atrioventricular blocking drugs, as we want to prevent the person from going into ventricular fibrillation. What are we most afraid of in the case of atrial fibrillation? That the impulses, that is the atria fibrillating, will get transferred to the ventricle and the ventricle will go into fibrillation. That is our utmost goal. That is, we should prevent the person to go into ventricular fibrillation, because the patient will not die from atrial fibrillation, and that too acute atrial fibrillation. The patient will not die. The patient will die from ventricular fibrillation. So we have to give drugs which will block the AV node. So there are 4 drugs we have which can block the AV node, and they are adenosine, A for adenosine, B for beta blockers, C for calcium channel blockers, and D for digoxin. So anyways, adenosine is not in the option, and adenosine is primarily useful for PSVT, as we all know. So second drug is beta blockers. So but we cannot use beta blockers in this case. We cannot use propranolol since it is a non-selective beta blocker, and even when esmolol, which is a cardioselective beta blocker, but still it has beta 2 blocking property, so we cannot use esmolol as well. So what is the third drug that we can use to control the atrial fibrillation in this case? That is the C drug, that is the calcium channel blocker. And as we all know, in the case of calcium channel blockers, there are verapamil and diltiazem which work on the heart, whereas the dihydropyridines like amlodipine, they are working in the peripheral circulation more. So the answer to this question is diltiazem. Now some important points about propyl thiouracil can be remembered by the word P. First of all, it is less potent than carbimazole, which is another anti-thyroid drug. Then propyl thiouracil has more plasma protein binding, and hence we require a huge loading dose of 1000 mg stat in the case of thyroid storm, followed by 250 mg fourth hourly. So why is loading dose required in the case of propyl thiouracil, it is because it has more plasma protein binding. So if a drug has more plasma protein binding, we will require more amount of the loading dose. And also, what is the main advantage of propyl thiouracil? That it is less teratogenic than carbimazole or thionamides. Hence, it is useful for thyrotoxicosis that happens in the first pregnancy. So if anywhere we are having first trimester of pregnancy, we prefer propyl thiouracil, but in the second and third trimesters we anyways prefer this thionamides, that is carbimazole or methimazole. So propyl thiouracil is anyways clinically not that much useful apart from thyroid storm. And what is the dosing of propranolol in the case of thyroid storm? It is 60 mg fourth hourly, whereas the normal dose in the case of diseases of hyperthyroidism like Graves' disease, the normal dose is 40 mg sixth hourly. So in the case of thyroid storm, the dose gets increased, that is, it is 60 mg fourth hourly. So that is how we should approach this question.